So we can see the entitled CO2 is up on the screen. We know that's warming up and it's going. The other parts of the circuit that we are concerned about is this here, often called a HEPA filter, but we call it HME in our respiratory world because we have dry gases coming through the ventilator and we want to make sure that they're humidified. This provides humidification to the patient because we don't have an active humidifier on this ventilator, and we typically will go this mode with all patients for about 48 hours, and then we'll switch them over to active humidification. So this passive humidification device does do the fact. It will also screen out COVID-19 and most every other bug that we know of at this point in time. Okay, so for COVID-19, this is considered safe. We want to make sure that's always on. The other part of it is our swivel, which is the one that actually connects to the endotracheal tube, and that's how we're going to connect the ventilator to the tube. So this is essentially what it should look like as a whole when you come in. This is all three pieces should be already assembled. You shouldn't even have to worry about it. So once we're happy with the settings and making sure everything's together, we want to make sure all our connections are tight. There's no leak. That sometimes you might obviously see these things sort of just hanging down. You want to make sure all those connections are on, nice and snug, and then you can hit your button that I said, the green button on the bottom, this one here, and that activates it. So I'm using the as a little test lung here. We're just going to put this on the bed. So now that we're ventilating, how do we know we're ventilating? So of course you're going to do your auscultation of the lungs. We're going to have obviously look at our entitled CO2. We have no entitled CO2 because there's no patient, of course. And you're going to look at for test rise, that sort of thing. With our waveforms, if you want to I'm just going to, actually we'll talk about alarms right now. So immediately we have an alarm activated. You can see it flashing yellow. It means caution. When it's flashing red, it means that's a really acute alarm. We have to fix that immediately. Yellow is for FYI kind of thing, right? So with our alarm profile, we see that the expiratory minute volume was low, and that was just because it was just registering, and we just set them up on the vent. That's a very typical alarm. Don't be alarmed by it, pardon the pun. To clear the alarms, we just have to hit the alarm button twice. Now our screen is clear. We don't have to worry about it. We will quickly check out our alarms. So we go to alarm profile, and we have our pressure, our minute volume alarms, respiratory rate alarms, and our PEEP alarms. And our pressure, of course, we're looking at, if we look at that and we look at compared to PEEP, or our PIPs rather, peak inspiratory pressures, which is 29 in this case, that's fine, because that's what was needed to achieve that tidal volume of 500. And if we look at our expiratory tidal volumes, and this says here, this is our kind of our patient data section, we can notice that the tidal volumes are in the 500 range. So everything is going well. Okay, so if I were to, for example, reduce the lung compliance of the patient right at this moment by just simulating that, we'll notice we'll get some alarms, and you can see the tidal volume drastically change. So what's happening now is the pressure, the PIP, is stepping up to try to achieve that tidal volume. And it's going to go up to that rate, that alarm of 40 that we talked about, and once it hits that level and it realizes it's still not getting that tidal volume, it'll let us know there's a problem, and we see the alarm comes up, regulation pressure limited. At that point, you have some stiff lungs or airway resistance, so it might be airway resistance requiring bronchodilators, or it may be just ARDS kind of picture for that we would expect from COVID. At that point, we'll have to look at the ARDS.net protocol, and then we'll have to go with lower tidal volumes as per ARDS.net, which you can get on the web, and I advise you to print it as much as you can if you're in that situation, and follow those guidelines. There's too many to really talk about it, but we're just talking about low tidal volumes, high PEEPs, and higher rates with permissive hypercapnia. Our FiO2s are always usually set at 100, and with that we would certainly increase our PEEP accordingly to achieve the oxygenation that you would like for that patient. So with these patients, the research I have read that you're going to be looking more like PEEPs of 20, 25, probably may not be in emerge, more in ICU setting. But if you need to increase your PaO2, then you're already maxed on the FiO2, then certainly going up to certainly going up on your PEEP is what you're going to need to do. Usually in increments of, initially I would just go increments right up to 10, and then you would sort of increment it in 3 or 4 at a time, and then titrate. And of course, one of the most adverse things is hypotension, and pneumothorax can result if you get too high. But you're just essentially at this point trying to keep your patient alive and trying to get as normalized ABGs as you can. Your rate is going to be used for anybody who's hypercarbic. Of course, we're going to have some permissive hypercapnia as well as your tidal volume, so you can treat your hypercapnia with your tidal volume and your respiratory rate, i.e. minute ventilation. And your O2, your oxygen will be treated with FiO2 and PEEP. Okay, those are your main parameters. It does get a little more convoluted than that, but for the purposes of this is all we really need to focus on. Again, going back to the waveforms, this is your pressure waveform up here. So the pressure waveform often we should have a nice square waveform, and you can notice that it correlates with a pressure PIP of 28 if we were looking on the scale. There's not a lot to get out of this. With the flow waveform, we notice this is how we would titrate our I time, and I'll get to, and what I time is, inspiratory time is, if we clicked on our mode, which is up here, we notice there's a few other settings. We have our basic settings, which were down here, but we also have an inspiratory time. So what we'll recommend is just go with 0.9, which is the default, 0.9 seconds. And usually that's all you need. Now, if you wanted to titrate your I time, there are some fine tuning that we can do according to our flow waveform. But again, it's not. I wouldn't consider that a critical thing to have to do in an emergency COVID situation. Finally is our volume waveform, and what's important about this volume waveform is basically what goes in must come out, so we want to make sure that it's even so that there's no big leak. So if we were to simulate a leak, for example, we would notice that we're really not getting a nice volume waveform anymore, and then of course the whole ventilator will go haywire because of noticing leak alarms. But we want to make sure that this volume waveform is what goes in goes out, and we also confirm that with VTI and VTE, which is the tidal volume inspired and tidal volume expired. They should be fairly close to one another. Sometimes there's some variances with air trapping and things of that nature, but they should be fairly close to each other. Okay, if there's a leak, you'll know it. It's usually pretty evident, as opposed to an IV where there's always a leak. Okay. If you did need to change your mode for whatever reason, again, we'll default to PRVC, but you can just hit the PRVC button as well. And then you want to go to a different mode, you go hit PRVC up here again, and then all the modes come up. In this case, we want to go, for example, pressure control ventilation, then we would just click on that. And then once you change something, if it's just the mode, you can hit accept or hit the toggle button here. You just push in. It's probably just as easy to hit accept as is on the screen. But let's, for example, to show you that if I want to increase the I time on pressure control mode, I would just, sorry, wrong button. I would just highlight it, turn the button here, and then I say I want an I time of 1.25 seconds and hit accept. Okay, and that's basically how we activate things. And right now we're in pressure control mode because I accepted it, but you can also, back to PRVC, you can also cancel it, but what we'll do is accept this mode here, back to PRVC, and I'll just go back to our initial settings. And that pretty much is how you would ventilate somebody in a pinch. Again, that button is to activate and deactivate it. If you want to go on transport, say we're done. So there's a couple steps you need to follow. The first thing you would do, what we recommend is patients still be ventilated. When you disconnect the circuit, the patient will be being bagged over. They need to have this filter in line. It's mainly, no matter what, we always have it in line. Specifically with COVID, it's critical. So we would take them off the vent, connect our bag here, so the patient never is breathing out the ambient air. So we would always have that. All right, so the bag would connect there. And at that point, we'll just reach over to the vent and just hit the button again. And then do you really want to go into standby? Yes. And that turns the vent off. And that is how we ventilate somebody and emerge.
All good?
Yeah.
Okay.